Can you hear me?
Yes.
I can't hear you.
Okay, we can hear you. It might be worth dialing, coming off and going back in again. Let's put this in the chat. Okay.
Okay, Chair, I think we're on air now. Just getting James to check it. Oh, just bear with me a second. Okay, sorry, just a slight technical error. Just bear with us.
Hi, Judith, can you hear us?
I can hear you now. I turned
Brilliant.
off and went away and came back again. Thank you for waiting, Mark.
No, don't worry. There's a technical problem as well, so we're just waiting for Lisa to come back to us after the check, so we can all hear you now.
Good. I can hear you too. How nice. What a joy.
I like that idea. Yeah, I like that idea of having that. Probably I've got my own.
So, Leonie, there's a technical problem, so we're just waiting for Lisa to come back.
Apologies, we're almost there, I think. It's just streaming to the wrong meeting. I don't know why.
Oh, what?
Not like this. So, right. Just waiting for the nod from James, who's kindly helping me. Okay.
Got nervous now.
I think that would be really. He does want to move. Okay, Chair, I think we're good to go.
Okay, thank you very much. Good afternoon, and good afternoon, members, attendees, and everyone online. Welcome to the Health and Overview and Scrutiny panel. I'm Councillor Mark Jeffrey, Chair of the panel. Members of the public are invited to view this meeting online. Those present are requested to keep their microphones on mute and to only turn them on when you're called to speak, please. Members are requested to keep your cameras turned on at all times. Officers and external presenters are requested to turn your cameras on only when you are presenting your reports or answering questions. Members have read the reports, so presenters, please just highlight any developments that have occurred since publication. If you would like to speak, please write your name and request to speak in the chat function or put your hand up. I would like to now invite those present to introduce themselves. So, Councillor Matthew Atkins, Councillor Leonie Oliver. She was online, wasn't she? She might have just had connection problems. Councillor Stuart Brown.
Good afternoon, everyone. Councillor Stuart Brown. I represent Fratton Ward in Portsmouth.
Councillor Graham Heaney.
Good afternoon. I'm Graham Heaney. I represent St Jude Ward in Portsmouth as a local councillor.
Councillor Judith Smythe.
Hello, everybody. I'm Councillor Judith Smythe. I represent St Jude Ward in Southsea.
Councillor Leonie Oliver, do you want to introduce yourself?
Sorry, I just spotted it was raining. I had to get the sheets in. Councillor Leonie Oliver for Baffins.
In Portsmouth.
In Portsmouth, sorry, yeah.
Councillor David Evans. Councillor Anne Briggs.
Good afternoon, everyone. I'm Anne Briggs, County Councillor for Waterloo and North Stakes Ward.
Thank you. Councillor Martin Pepper.
Councillor Martin Pepper, Gosport Borough Council. Thank you.
Thank you. Councillor Vivian Ashwell.
Yes, good afternoon. Councillor Vivian Atchell, representing Whiteley and Shedfield Ward and Winchester City Councillor.
And last but not least, Councillor Julie Richardson.
Good afternoon, everybody. I'm Councillor Julie Richardson. I represent Havant Borough Council and I'm a councillor in Hayling West Ward.
Okay. Thank you very much. Can I just check with, are there any apologies that have been given at all?
I've received no apologies, Chair.
Okay. So next item, declarations of interest. One of the surgery that I use is mentioned today, so I'd like to declare a sort of personal interest in that. And do we have any other declarations of interest? Councillor Stuart Brown.
Thanks, Chair. Yes, exactly the same. I'm a registered patient at Lake Road, which is part of Island City Practice, mentioned in one of the reports.
Okay, so I don't know if I need to say mine is Craneswater Practice. So next, Councillor Judith Smythe.
My practice, the Trafalgar practice in Southsea, is also mentioned. And I'm feeling very cheerful at the moment because I've just had a major operation in QA and it all went really well and I'm very grateful.
Good. Very pleased to hear that. Councillor Leonie Oliver.
Yeah, the same. I'm a patient at East Shore Partnership that's mentioned in the report.
Are there any other declarations of interest? No. Okay, let's move on. Councillor Graham Heaney.
I'm just going to not declare an interest because the item is an information item. There's no decision to be made, so I don't think I have to declare an interest.
That's true.
So I'm not going to.
Okay,
that's
understood.
Quite true.
Yeah, you're right. Agenda item 3, minutes of the previous meeting. So should we go through the minutes by page? And if anyone has anything that comes up from it, just say. So page 3 on our report, agenda item. Page 4, 5, 6, 7, 8, 9, and finally 10.
On page 10, I think the HOSP dates are for 24-25, not 23-24.
I think you're absolutely
Item
right.
9.
Yeah. We can get that changed, so that's correct.
It needs to be changed because diaries are tricky enough anyway. Thank you.
We can't really go back in time, can we? Thank you for that. Is there anything else on page 10? Okay, so agenda item 4 is adult social care self-assessment, preparing for inspection. So we've got Andy Biddle and Debbie Young, Portsmouth City Council. So I don't know which one of you is presenting first or telling us first. Is it Andy? Hi, Andy.
Thank you, Chair. Good afternoon, members. So very grateful to be joined by Debbie Young, our Head of Quality and Performance, and I'm the Director of Adult Social Care in Portsmouth. All right, so the report before you is a covering report for the self-assessment document, which is contained at Appendix 1. And the self-assessment's been prepared as part of the preparation for the Care Quality Commission inspection of how the council meets its duties and responsibilities under the Care Act 2014. Just a few notes. I won't go through the whole report, as take your point, Chair, that the reports have been read. So in terms of the background, that's the main section of the report. It sets out the statutory nature of the inspection regime and the timeframe for inspection of all 153 local authorities with adult social care responsibilities. That section also contains more detail about the how of how the inspection will be conducted, including the potential outcomes. There are 4 single-word outcomes that will be a judgment will be made at the end of each inspection for each council as to which word fits each council. There is an acronym there that we haven't defined. My apologies. DASS, D-A-S-S, stands for Director of Adult Social Services. That's a statutory title. All the other acronyms, I think, there have been defined, but my apologies, that one wasn't. The section also sets out the activity undertaken.
I don't think those are not outcomes. They're measures of outcomes, aren't they? The outcomes for patients and clients might be quite different, and you've tried to capture that in the report.
Yes, absolutely, Councillor. You're absolutely right. Sorry, the outcome for the authority will be a single word judgment, but the outcomes for individuals and how the council is assessed and judged are. There's a lot more information in Appendix 1 around that, and it's quite helpfully described as I statements and we statements. We statements being the ones that the council would say about itself, and then I statements being the ones that we would hope that our residents would say about the care and support that they receive. So, yeah, take that correction, absolutely.
Yeah.
So the section goes on to set out the activity undertaken to produce that self-assessment, and that falls into several areas. So there was work with staff internally in the council, work with the main partners that we work with, either the health service or the police or local voluntary agencies, for example, and then most importantly work with our residents, undertaken through a variety of methods to come to a judgment, a reasonable self-assessment judgment of where we think we are in the work that we do, and then the improvement plan, improvements that we think we need to make. We then, coming to the end of that section, the report then highlights some of the successes and challenges, just picks out a couple of those, but again, there's much more information in all of those appendices. So our next steps with this particular process, we received approval from Cabinet on the 5th of March. To the recommendations that we made, one of which was to move all of this information into an improvement plan for adult social care to be worked on in the 24-25 financial year, and we'll be bringing that improvement plan back to Cabinet in June of this year, this calendar year, and obviously if HOSP would like us to, we can bring that improvement plan and some of the outputs back to this panel as well. So that's a broad summary of the documents that we've got there for you, but as always, happy to take any questions or queries. You're on mute, Chair.
Sorry, someone turned my microphone off. Councillor Judith Smythe, I know you've put your hand up for a question.
I did. This seems very comprehensive, and I'm very glad to see it is in the I and the we statements, giving agency to all these things. That's an improvement on documents like this that I've seen in the last 10 years. Do we have a date? And I have read all this, but I couldn't see it, when we think the actual inspection will be done. And second of all, will they actually come down and test this out? And third, will we have a chance to see the action plan that results from the areas for development that you've identified? And can they be quantified in terms of outcomes for individuals, rather than, yes, we've set up this partnership, yes, we've strengthened operational links. And, we need to see fewer older people are turning up into hospital as emergencies, more older people reporting good quality of life, for example. The sort of thing.
Yes, thank you for that. So we don't know when CQC will turn up. We do know that all 153 local authorities will need to have an assessment process between December of last calendar year and December 2025. We do know that when they do turn up, or before they turn up, sorry, they'll contact us and say to us, you're now on the list, you're going to be subject for an inspection, and they'll then ask for a certain amount of information to be returned. And they'll then guarantee to give us a minimum of 6 to 8 weeks notice before they actually turn up on site. But it could be from the point that they send us the letter saying you're next on the list, it could be any time from sort of 9 weeks to 6 months before they actually turn up, because of the timetabling and the planning that CQC themselves are doing. So that comes on to another of your questions about, yes, they will do some site work, and that site work will mainly be interviews with groups of staff, with groups of colleagues, groups of partners, but they'll also be talking directly to people that access services within Portsmouth. So they'll be looking for that lived experience element to that inspection. In terms of the improvement plan, we can bring the improvement plan back to HOS. We've committed to bring that back to Cabinet, and the improvement plan will be couched very much in outcomes for people. Because of this thing, here is what we will do, and here is how we will measure that we've done it. In very simple terms and accessible terms. So yeah, we're absolutely planning to do that. It's worth commenting, before they turn up on site, they'll do quite a lot of work looking at freely available published data around adult social care in Portsmouth. They'll also start talking to those people that we work with on a professional level in Portsmouth before they actually turn up on site. So they'll have quite a lot of work done before they get there. There'll only be 2 days on site in total, but they're anticipating that the pre-work that they do, plus those 2 days on site, will enable them to get enough evidence together to triangulate a judgment. And then we'll then have the usual process of having a report sent to us for factual accuracy. So if we vehemently disagree with some of those points, we can submit some factual accuracy questions. We then get a sign-off of draft, and we then know when it's published, and we inform and communicate to everyone when it will be published on the website. Hopefully, I think that answers most of your questions, but happy to take any further.
I know you've got your hand up. Do you want to follow up, Councillor Smythe?
Yes, please. I mean, as usual, I would like to see a lot of the things that are areas for development are perfectly logical, and I know they're based on good practice in my experience, but none of them, they're all ones which I would say, so what? Let me give a simple example. Developing an overarching accommodation strategy. Yes, a great thing to do. Fantastic. But if I was homeless on the streets of Portsmouth, I'd be saying, so what? You can have the best strategy written down you like, and nothing improves for anybody who needs housing. And I do think it does need sharpening up quite a bit to make sure that we are able to see if life is improving for our many clients, both across health and social care. In most of these plans, there's some way of measuring whether people actually feel better after they've had something from us or not, or whether they're not going to feel better because it's not that sort of condition, or whether they think it was useful or whatever. There's an awful lot of so what in this. You probably know I used to do national consultancy on this. It says again, consider the impact of digital exclusion. Yes, absolutely great that we know what the impact is, but I want to reduce the impact of digital inclusion. And of course, on the way, consider it. And it's very, very heavy on things I would say, so what to.
Yeah, I think you... Oh, sorry.
I do, as you know, I bring up this thing that I'm so passionate about once a year, and this is it for this year. I don't want to... But actually, there's a lot of so what in here.
And there is necessarily, I think, because this is very much a summary, but what we tried to do, there's various templates for create.
I think that the summary is the overarching objective, which is based on outcomes for people. And then these things are vitally important, of course. But if you were involved in any of these, you could be justified for saying, so what? Why are we doing this? Arranging another series of meetings. Why are we doing this? Writing another strategy. I want to see head on that we are really focused on outcomes for individuals with a huge range of issues. And obviously, they must necessarily be at the highest level thing you have in this document.
Thank you. So, Andy?
Oh, sorry. Yeah, so I think this is very much a summary. We wanted to keep something that was accessible, that was simple and straightforward, because what we didn't want to do was do 100 pages worth of plan, which we could have done, because that's not designed to be a publicly accessible document. So the improvement plan will translate what we've put in these areas for improvement into outcomes. Just to take one example, I guess, so with the accommodation strategy, what that should say to us is how many of our residents need an element of care and accommodation, and how are we planning for that? So we know at the moment we've got X number of extra care spaces, for example. Well, actually, the strategy should simply be a plan for, we think in X number of years we'll need this many more, therefore we need to think about building. Therefore, we have less people going into residential care because we can care for more people in extra care with their own front door, their care on site, their independence and wellbeing, those sort of things. So I think this really is very summative, and I take your point about the so what, but what we hope to do, and what you'll be able to judge, I think, is we draw the so what out through the improvement plan, which we then account for, monitor, and say what's the difference between where we were here and where we were now. Hopefully that's a reasonable response to that. We will draw that out in more detail.
The very last comment on that is I'm not that interested in some ways where we are with all our meetings and strategies. I'm interested on where individuals feel and what they have got out of the, whether it's a big or a small involvement in public services from health and social care. And I know that we are actually thinking like that, and we are doing it because very usefully I met your community development and inclusion team yesterday. It was very good. But, the important thing is that individuals, a greater number of individuals feel better, reasonably satisfied, and more independent from public services than they did last year. And I really do think we've got to strengthen up on that aspect. I'll shut up now.
Okay, thank you very much. Councillor Julie Richardson.
Thank you, Chair. Hello, Andy. Yes, I absolutely agree with Councillor Smythe, but I suppose you would expect for some of this to be pulled out in the CQC report ultimately. Mm-hmm. So some of those things that Judith is talking about, they'll be tested and pulled out in the report.
Absolutely.
Yes. And the other part of my question is, having done your pre-assessment, how do you think you fare?
I think we do a lot of things well, and I say that on the basis of the feedback from our residents, really. One of the things that stands out in Portsmouth, I think, is that our residents say to us they can get hold of us relatively easily. Not everyone does. People have problems, and not everything's perfect by any stretch. But we know that we are a relatively small, relatively compact local authority, and we have a lot of services that deal with individuals personally, rather than directing people to self-service. The service that Councillor Smythe was just talking about, the independence and wellbeing team, work with a lot of people who may need services in the future, and if we can help them develop their independence and wellbeing skills, we can prevent that happening. We work with a lot of our communities that aren't necessarily served by the mainstream, I think it's probably fair to say. And so we think there's a personal relationship with people. We also, some of our national statistics that we pull together, people say they find it quite easy to get information about our services. And often people are approaching social care at a really difficult time in their life. It's not as well publicised as the National Health Service, for example. Not as many people have a really clear understanding of it. And so that's really valuable. I think the working that we do as an integrated system. So, for example, if you're a resident with a learning disability in Portsmouth, your health needs and your social care needs are met in the same place because we have an integrated team. So I think there's a lot of quite significant positives to that self-assessment. I think we've got some work for improvement, and I think that the key for us is when CQC pitch up is being able to say, here's our honest account of where we think we are. We know ourselves, and we also know the improvements that we need to make. And so you shouldn't find any surprises here. And that's the really key test, I think. So I think we're doing well in a lot of areas. There's room for improvement around direct payments, for example, to give people more control over how they manage their care. We need to get better at working with people and helping them shape what we do for them. So that co-production element, we do it well in some parts of the service, but not all across the service. So we've got some quite significant chunks of work to do, I think. But I think we're in a reasonable place.
So are you expecting a needs improvement or a good?
I really wouldn't like to second guess CQC. This is the first year. Much. No, not at all. This is the first year of these inspections, and we're studying very intensely those authorities that have been inspected, and their results are declared, and learning from those. Yeah, I wouldn't like to second guess.
Thank you, Andy. Thank you.
Thank you. Next is Councillor Graham Heaney.
Thank you, Mark. I just want to ask a question about page 29 of the report. On one of the areas for development, it says consistently compare regional and statistical neighbour performance on key measures. That assumes we're not currently doing that, and is the reason for that because statistics are not easily available? Because
you've gone on mute, Councillor.
Yeah, I was just saying there used to be a body called the Audit Commission who would do some of this work and make it available. So is that the reason we haven't got it? It's just difficult to come by. And if so, where can we see this data? Because I think some of us would be quite interested to compare our position with other local authorities to see, where there are differences and maybe why those differences exist.
It's a real mix. So there's to answer to start at the beginning, really. There is data. There's nationally available data. We do use it. I think the key word is consistently. I think what we've had in the past is not a consistent use of that data. And then, of course, go back to Councillor Smythe's, the so what of that data. How does that then guide us and help us in what we do and how we improve? That being said, there is currently a sea change in how data is collected. So we've moved from submitting chunks of data to the Department of Health and Social Care, which is the main body that collects our data, into something called client level data. So it's individual outcomes for people. And that then gets aggregated up at a national level rather than the local authority submitting a broad span of data. And we're in, I think it's fair to say, we're in a bit of a handover period between those two methods currently. We can certainly share with HOSP, and we can get it added to the minutes, the data that is currently nationally available, and we can put some working around those statistical neighbours, nearest statistical neighbours. In fact, we had a presentation yesterday to our all managers meeting around how we compare to those neighbours. So we can do. As always, national data is a bit of a blunt tool. So for instance, most carers in Portsmouth that we know say that it's easy to find information about our services, but that doesn't really give you that individual outcome or where we need to really improve around that. That doesn't give you that more granular aspect, I think, that we can collect locally. So yes, there is data. There's a transition between two methods of collection currently that we're working with GHSC on, and yes, we can certainly let you have a look at some of that for our nearest statistical neighbours.
Right, that's lovely. Thank you, Andy.
Thank you. Next, I've got Councillor Ashwell, please.
Thank you, Chair. Hi, Andy. I just wanted to go on page 49, the adult social care self-assessment feedback. I noticed we've had 220 responses to this online survey.
Yeah.
Do you think that's a good number of people, or is that on the lower side, higher side? Have you done this before? How does it compare?
We haven't done this before. I think we've done this. We've always been subject to some of the council-wide surveys that we see, because of course we're part of those services, and we do something called a carers survey every other year, which is related to those people that are informal carers in Portsmouth, and we have what they call a social care survey that goes out every year. But those are very much questions that are sculpted by the centre, by the DHSC, whereas this particular report that we commissioned was very much around helping us with our self-assessment, helping us understand what residents thought of the services we provide and the customer service we provide. I think 220 is pretty good. We work with, I'm just trying to think of the numbers. The numbers for those people that get a funded service are quite different from the numbers of all the people we go. So we work with roughly about 2,000 people in the city, give or take. So this would be about a 10% response rate. That's not bad. I mean, I'm not a statistician by trade, and Debbie might want to come in and give her view on that. But I think a 10% response, that's not a bad response. So it should be relatively representative.
Chair, can I just ask a supplementary? So
yes, of course, yeah.
Was the survey all online?
There's various. So if I just refer, we used 4 methods. So we had an online survey. 3 methods: an online survey, postal survey, and then interviews. So we asked the corporate engagement team when they were out doing some door knocking around the city to put in some questions about social care. We used a postal survey because from some of the carer surveys and the regular surveys we're involved in, the national ones, some people will say to us, yes, I'd like to be involved in any future work you're doing. So the postal survey was directed mainly toward those residents. And then we had the door knocking from the engagement team. So it was trying to vary that method in the understanding really that not everyone feels able to use the digital methods. So trying to get a bit of a spread.
Okay. Thanks, Andy.
Thank you, Debbie. Debbie's just put in the chat the 220 refers to face-to-face.
So are there any more questions from members or does anyone else want to speak? No? Thank you very much. So thank you very much, Andy and Debbie. We've noted your report. You're welcome to stay during the meeting, but equally, if you need to get on and do other things, please go. So thank you very much. So next we've got agenda item 5, which is the ICB Recovery Support Programme, an update. So I think we've got Dan Gibbs, Chief Delivery Officer, and Martin Sheldon, Deputy Chief Executive. So Dan and Martin, could you give us a brief summary of your report, and then members will ask questions. Thank you.
Good afternoon, Chair. Good afternoon, members of the HOSP. This afternoon you have myself, Dan Gibbs. I'm the Chief Delivery Officer for the NHS in Hampshire and the Isle of Wight. Unfortunately, Martin can't be with us this afternoon to contribute to the conversation. Although we are trying to get him to come into the call, so he may appear partway through the presentation, but I'm fully lined up to answer any questions that members of the panel may have. Hopefully you've all had a chance to read the paper that we've submitted. It essentially outlines where we are in terms of our financial position as an individual organisation, the ICB, but also projects our financial outcome as a system, which is bringing together the financial positions of not just the Integrated Care Board, but also all the acute community mental health NHS providers in our system, alongside our ambulance provider, which not only covers Hampshire and the Isle of Wight, but also Frimley and the Berkshire, Oxfordshire and Buckinghamshire ICBs as well. We are in what is known as recovery support, which we've entered into voluntarily, which is the NHS England programme to support challenged organisations and challenged systems to improve their position, and that's detailed in the paper as well. We are also now pleased that the Chancellor has announced his budget, which is kind of operational issues that's been a theme for us and for our partners in local authorities and in acute trusts. But Chair, I won't take up any more time on intros if that's acceptable to you, and head straight for questions. Over.
Okay, thank you very much. So questions on the financial report first. Do we have any members' questions? Councillor Graham Heaney, please.
Thank you, Mark. Well, thank you, Dan, for that. I did want to ask about the coming financial year. Will the system have a potential deficit or a savings target to meet in the new financial year? And how much is that likely to be?
Thank you, Councillor. Great question. So typically we would look for cost savings of around 4% across the board. The situation next year will be slightly complicated by some of the financial requirements that we need to meet for NHS England, in that we will need to begin the process of paying back the deficit that we have created in this financial year, as well as delivering cost improvement savings, not just in terms of operating costs, but also in terms of financial efficiency for our programme budget as well. In the paper, we've also outlined, you may recall that the previous Minister for Health instructed the NHS to deliver an operating cost saving for integrated care boards, which is 20% for financial year 24-25, followed by 10% additional on top of that for the following year, which we've been working very hard throughout this year to aim to achieve. So in all, I can't do the mental maths right now to give you the total percentage figure, but we need to find a way to deliver probably around 4% cost improvement, plus pay back the deficit position of the 105 that's noted in the paper, plus deal with any non-recurrent savings identified in year, plus land our 20% operating cost reduction, plus plan for the further 10% for the following year. Over.
Thank you. Did you have a follow-up question?
I do, yes. I mean, I understand, if I am correct, and please correct me if I'm wrong, that the budget for the ICB is in the order of £3 billion. Is that correct?
It's roughly £3.8 billion, Councillor, yes.
Yeah. And when you talk about the savings, are you talking about the whole, out of the whole budget, or are you talking about something different?
Yeah, so again, quite a complicated picture. So there is a significant proportion of our programme budget, which is the monies that we are allocated nationally to commission services that are, for want of a better description, ring fence for certain things. So there are elements within that that are allocated for the provision of acute care, primary care. There are some lines associated with inflation costs and so on. The way that we approach, for example, the 4% is on essentially operational savings that we need to identify. So making our services more efficient, reducing the cost of the delivery of the services to allow us to be able to accommodate growth and inflationary costs over and above those allocated within the programme budget. Over.
Thank you. Councillor Heaney, did you have any more follow-ups?
Yeah, I'm sorry, I do, yes.
Don't apologise.
We're obviously establishing a new integrated trust, which there's a further report on it later on the agenda. Is that trust also going to be included in any savings targets? Will they have to meet savings targets too?
All organisations, Councillor, have savings targets that they need to achieve, and there's quite a lot of freedom for individual CFOs to establish what that number is for each organisation. We've been very fortunate with the two organisations who are coming together as part of the Fusion programme, in that they're both in reasonably good financial position this year, but obviously that remains a challenge for the teams to be thinking about. And I do know that I think maybe you've got Andrew Strevins, the CEO of Solent, joining later, and one of the exec team members from Southern Health. They may be able to report in more detail on this, but I know that the teams are working hard to think about and create the plan for 24-25 to deliver savings in those organisations. Over.
Given the timescales you've mentioned, I mean, you're not going to be able to produce clear financial plans and budgets probably at least 2 months, maybe 3 months into the new financial year. Is that a reasonable assumption? And then I've got a follow-up to that as well. I'm sorry.
So again, on the top line, we're going through a process of planning submission with NHS England. So there will be a period of time that it will take us to get to a final position of what our plan and our agreed deliverable end of year position will be, Councillor. But that because we're now in a stronger position in terms of knowing what the envelope that we're working to, that won't now inhibit us being able to firm up numbers, allocations, etc. For example, for the Better Care Fund for our partner organisations. So we've started the process of notifying partners of what those might be to allow more certainty in planning for our partner organisations. But yes, fundamentally, we will be into the new financial year before we know what the position will be at the end of that financial year. So yes, over.
Graham.
You've talked in the report briefly about you've made savings around sort of corporate management and so on, and obviously there is, you've done quite a bit. You've anticipated you can do more on that, but I'm thinking that the figures that you're talking about, although we can't maybe pin them down exactly, are going to be quite substantial. So what is the impact going to be on service delivery of having to meet these budgetary requirements in the next financial year?
Yeah, that's a really important question. Thank you, Councillor. So I think one of the things that we absolutely have to do is we have to recognise where we've got inherent inefficiency and deal with that. So I'll give you an example. It's not in Portsmouth City Council, it's in one of the other councils, but in some of our out of hospital capacity, we've had a starting point where we have people staying in out of hospital capacity for an average of 42 days, which is a really long time, 6 weeks. And there's been a lot of work to bring that down to 24 days. Colleagues in our partner organisations have identified that maybe we could go even further on that, down to about 7 to 10 days, which if you think we've been commissioning about 140 spaces in that particular council, if we're able to reduce the length of stay for people in those spaces by 60% and reduce our reliance on that, we can potentially either increase throughput and therefore deliver efficiencies in the acute sector, because one of our biggest problems, and I'm fairly certain that Lee and Mark will talk about this when they come to give the presentation on Portsmouth hospitals. One of our biggest issues is the number of people in our acute hospitals and in our mental health and community hospitals who medically don't need to be there. So either we can deliver efficiency, financial efficiency by needing less of a thing, or we can improve productivity and throughput and therefore, for example, do more planned operations through the space that's created, reduce the costs to the acute trusts in terms of the temporary workforce that they deploy to deal with things like escalation capacity during extreme times. We benefit from, forgive me if you've already had presentations on the elective recovery fund, but we benefit from a financial top up if we hit a particular productivity target. So for Hampshire and the Isle of Wight, I think it's 108% of 1920 levels of planned care activity. We benefit from additional, for want of a better description, bunts for doing that work. There's a financial top up that we can aim for that can support us for doing more work through the acute sector. So our aim is actually to improve as much as we can the services that we deliver to residents in Hampshire and the Isle of Wight, whilst aiming to do that in a way that reduces the cost to the taxpayer as well. So that's obviously the challenge that all public services face. But our goal is to deliver services that are effective and add value to the experience of accessing healthcare, not to remove services unless there's a kind of warranted need to do that, or we can deliver it in a better way. Over.
Does that answer your question, Graham?
It does in part, but I've got two more questions. I don't know, I'll stop and let someone else go in. I understand that the current budgetary position has prevented anyone within the ICB from applying for new initiatives. One of the ones that I have been told about is to work with the DWP, supporting people back into work. Now, we know that there are a number of people who are not working because of health issues, and I understand that we haven't been able to apply for that with local authorities. And I think that decision seems a bit irrational, since we're trying to get more people back into work. And I'm wondering, is that true? And is there a block on new initiatives being applied for?
Thanks for the question, Councillor. First of all, forgive me, I'm not familiar with the detail of the particular example that you've cited. So I will happily go away and have a look into that individual issue and respond more fully in due course if that's acceptable to the panel. Yep. But generally speaking, whilst we are in recovery support, and that essentially means that there are extremely enhanced financial controls. So, for example, every week we have a quorum of executive directors meeting to review every spending decision. What that doesn't mean is that we're not supporting new projects if they're warranted. So we absolutely have a process to consider proposals from within the system where the ICB is the decision maker on investment in those. But clearly, when we're in this challenge position, as with any organisation in a similar position, we have enhanced governance around the decision making, which is a requirement of our status in recovery support. Over.
My final question is, I mean, obviously a lot of what is happening at the moment is quite inward looking in terms of trying to find savings. Is the ICB looking to either find out, learn about, or draw on the experience of other ICBs that are not in quite the same difficulty? There are examples, I think, of ICBs who are not in the same financial difficulty, although some of them are. And are you looking outward to try and learn what you can in order to try and make things better? Because whilst I appreciate everything's been going on, it seems like we've got a leaky boat. You've got a bigger bucket to bail the water out from the leaky boat, but you haven't solved the leak, which is my analogy for where we are. So are you able to look further afield at what is good practice and where we might learn from things that we could implement maybe here later?
Thank you, Councillor. And may I also add, we normally try and boil the ocean while we're trying to fix the leaky boat. But absolutely, yes. So there are numerous examples where we're taking advantage of the interconnectivity of the NHS to do that. I, for example, am going to be reaching out to Mid and South Essex, who've done some great work looking at reducing the number of people in hospital that don't need to be there. That's generated improved experience and outcome for patients, which is obviously the most important thing that we need to drive towards, but also has produced financial efficiency, not just for the NHS, but also for partner organisations and local authorities. So we're absolutely connecting where there is good practice. I'm in a way, I'm sad to say what I'm about to say. I'm pleased to say that we're moving up the ranks in terms of our financial improvement counsellor. Many of the 42 ICBs across England are finding themselves in the same boat as us. But I'm always up for learning about how people are doing things better and adopting and adapting that for our own purpose. So if anyone on the panel would like to highlight an area that they've known about, I'd be grateful to hear it. Over.
Thank you. We'll go to, I've got hands up next from Councillor Gia Smythe, please.
Thank you very much. I'm following up from Graham's questions, really, and indeed, thank you, Graham, for Councillor Heaney for asking some of the questions I had on my list. I think this report doesn't do justice to the absolutely terrible position we're in. We are, the fact we have to pay back previous year deficits in effect means that we have got a cut to budgets this year. We are also got the various controls, which some of which will be very helpful and some not. When I was in hospital 3 weeks ago, it was evident that the whole of the hospital was under tremendous strain, and there was a very clear understanding among all the patients I talked to in various places that everybody understood that. And I think there's a good deal of public concern about that. Waiting lists are still not being dealt with quickly enough, and therefore you're dealing essentially with a more entrenched problem when the time comes to actually deal with it. And I was very conscious of that as an inpatient for 48 hours after a serious operation. I think is there anything we can do as a health overview and scrutiny panel, joined up with the local authorities, to put pressure on the department, on the government, to recognise we cannot actually cut the service at the moment in the way that you're saying. I remember from the days when I was chair of the health authority, we did talk glibly about making efficiency savings quite a lot, and actually it's extraordinarily difficult to do. And I can see, there's always that little hope that you'll be able to do that. You can use 24-hour surgeries, and then it pulls on an amount of staff you've got and so on and so forth. So first question is there anything we can do as your partners to make sure we have a bit more money in our system locally? And second of all, can we, so that's the first question about whether we can help and do something about it. The second question is about agency staff. The whole thing that people talk about it at times, but not other times, is the excessive use of agency staff. Have you got an assessment across the whole of the ICB patch about the number of agency staff used? And have we got a very, very clear HR strategy for the Integrated Care Board in order to increase employment direct employment in the NHS, bringing people back from retirement possibly, recruitment and retention packages, more flexible working for people with certain home care responsibilities. You know the list as well as I do. But if we haven't got that sort of plan, and there are a couple of other plans to do with efficient use of shared premises, which I think we might want, I would want reassurance that you've got, then I don't think we're doing enough. So there's those two questions, please.
Thank you, Councillor. So I'll start with the first one, if I may, and then get into the second one a little bit. So first of all, I think it would be, I think that we absolutely have to hold the mirror up to the way that we have been working in the past. There are many examples of multiplication of things that have existed in Hampshire and the Isle of Wight. Doing the same thing 7 times over when we potentially could do it once really presents itself as an opportunity. So I think that we absolutely have to hold the mirror up to ourselves and ask ourselves, are we doing the best that we possibly can do? But in terms of help with the department, I would say all help gratefully received. I think one of our biggest areas of concern, and I don't profess to be an expert in this, and we have Mr. Biddle on the call to do that, but I think certainly making sure that we can properly support social care for both adults and children and young people, that would be a really make a really profound difference nationally to the delivery of healthcare. And I think that's one of the areas we obviously have some amazing things happening in Portsmouth and the surrounds to support people both before they get into hospital, but also on the way out as well. But I think that would probably be the one area that I would actively seek support on. On the second point, so on agency staffing and efficiencies, I think I'll be really happy to share the detail of our workforce transformation plan with the panel. We'd be happy to come back and talk to that and bring our Chief People Officer. Workforce transformation is one of the 5 pillars of change that we've adopted for Hampshire and the Isle of Wight. The others being urgent and emergency care, discharge, local care and planned care. Actually we have one of our CEOs leading that, Ron Shields from Southern Health, as the steward of the workforce programme, is very much looking at how we can reduce agency costs. I don't want to steal Mark's thunder from later, but Portsmouth Hospitals, for example, has done an absolutely amazing job of reducing their agency spend for trained nurses to 0, which is just phenomenal. And actually, if you talk to Prof. Ricks, the chief nurse at QA, she'll say that because they've done such an amazing job at recruitment of trained nurses, they've been able to cope with some of the additional challenges and pressures through winter in a way that they wouldn't have been able to do had they been reliant on agency staffing in quite the same way as they have been in the past. So bravo to Portsmouth Hospitals for that. So our teams in those hospitals are working incredibly hard to address that problem. I think one of the constraints, and this kind of flips back into question 1, Councillor, one of the constraints that we'll face in coming years will be the pipeline of professionals coming into the system. So I think we need to be working with all of our partners, and I know Danny Hararam, our Chief People Officer, is doing so, about how we can create opportunities for local people to be inspired to pick up careers in health and social care, and train and remain to deliver services locally as much as possible. So that would be another area. I'll just add on to my question 1 response. But as I said, in terms of the detail, I think you were interested in getting assurance on some of the detail around that. We'd be happy to bring a report back to the panel with some of the numbers and some of the work that's going on around that to provide assurance. Over.
That'd be useful. Councillor Smythe, do you have any follow-ups from that?
Yes. I mean, one of your pillars of your reform programme, which I think we had had a bit more insight in the report last time round, is local. And I think that both Portsmouth and Southampton have done some very good local work, integrated working. Nationally, Portsmouth's integrated working between health, social care and the voluntary sector and the community sector and carers is, or certainly was, one of the best in the country. And you, behind your word of local, you'll talk, and indeed on the paper that there is here about the aspirations for the new Community Health Trust, it's all about consistency and uniformity. I'm afraid living and working in Portsmouth all my life, I don't think that is compatible with your use of the word local. And I would hate to see resources wasted in unwinding all that good work that's gone on, particularly in Portsmouth and Southampton, the 2 cities within your area, the 2 large cities. And I think particularly Portsmouth is good at this, by unravelling years of good interagency work that's been established locally. And I think for that reason, we must move the Health and Wellbeing Board and the Health Overview and Scrutiny Panel into some very locality conscious scrutiny and objective analysis of whether or not the idea the ICB quite understandably has of making everything uniform. I don't think the NHS works that well when it's trying to offer uniform services to Middle Wallop and Charles Dickens Ward in Portsmouth, for example. And the sort of things that GPs can do in those settings to start with is very different. And I could go on. So I'm really worried about the ICB kind of thinking it's more efficient to unravel things that are working well in particular localities. And this was always a worry I had about ICBs. I'm on record as having commented earlier on that. I used to be chair of the Health Authority. We had the problem in a much smaller area in Portsmouth, South East Hampshire, nearly 20 years ago. And I will always be vigilant about that. But can you comment, please? What do you mean by local as one of your pillars?
Thank you, Councillor. So I think that I've got a few things to say about this. So the first thing is I've been inspired by and celebrate the work that's happened in the integrated units at HCP in particular, and in previous lives working with other local authorities in London and elsewhere. So I firmly believe in the value of integration and doing things in partnership. I also think that if you take, for example, the COVID vaccination programme, for which I worked regionally as the strategic director for South East England, when we had the most successful uptake, it was in the hyper-localised approach, and Hampshire and the Isle of Wight and Portsmouth, Southampton in particular really drove that and in many ways influenced what happened across the totality of England. So my view on it is that where we need to vary in a warranted fashion, where the local community needs a differential approach, we need to be able to support and continue to do that. And I'm going to sound a bit like I'm giving work to my colleagues a little bit, but I would also like to create the opportunity for Lara Alloway, our Chief Medical Officer, to come and talk to you about our local and primary care strategy, which is very much focused on the idea of integrated neighbourhood teams and bringing teams together locally around residents and around patients. So when we talk about standardisation, council and standardisation, it's at scale. And Andrew, I'm sure will talk in more detail or more eloquently about this than I can. We talk about probably the sort of end bit of the whole pathway, where we've got lots of different ways of doing things in hospitals and with services. Well, actually, we could adopt best practice across the board. And we've got two great organisations with loads of innovation in the way that they deliver adult mental health services, for example, and community services. But we have to make sure that when we do develop service models, that we do it in partnership with our partners in local authorities, with primary care, with practitioners, and with the community itself. So in the pillar of transformation, when we're looking at bringing together organisations and creating opportunity through synthesis, that may extend itself more through how we work in terms of corporate support services and things like that. But we do need to retain that hyper locality, because we can make a massive difference through that. So this isn't a dodge, Chair, please forgive me, but I would like to create the opportunity that we could bring the integrated neighbourhood team strategy to the HOSP, so that you can review that and be assured that remains very firmly a part of what we're trying to do. Over.
I mean, I think we would definitely welcome that. So if that could happen for the next meeting, that would be fantastic. I've got a quick question which touches on what Councillor Smythe was talking about, really. So
last question I had.
Could I? No, I was sorry, speaking. Yeah. Okay. Yeah. No. So sorry. Can I just finish my question? So the ICBs were really created to pull social care and what was the CCG work together, and Portsmouth had a really good worked really well in this area. Are there any areas of the country where places have pulled out of an ICB? Because it's all about health outcomes, and we specifically got an interest in Portsmouth. Should Portsmouth pull out of the ICB?
Thank you, Chair. It's a really interesting question. I think so. The local authorities' strategic direction is very much for the local authority to decide and agree. Our position is that we've got something really, really great. We're obviously in a really challenging situation, but how can we continue to support the great stuff that's happening in HCP and grow and develop it in the future? And the only way we're going to do that is in partnership with Portsmouth City Council and with Solent and others who are involved in that. So my view is we're only going to be successful in delivering the services that we do together if we work at doing that as a team. So I don't think that you should withdraw from that. I think there is a lot of benefit to be yielded. I think the real opportunity that we do have is to take the good stuff and take the learning from all the years of hard work that have gone into creating that partnership and finding a way to share that further across our system. I'm not aware of any particular place that has pulled out of an ICS yet. It may be that there are. I haven't researched it. I will absolutely go and research that going away from here. But I think that we have the privilege of being the first ICB to go through this process, and it's a learning process for NHS England in totality. And without a shadow of a doubt, it's difficult. It's not easy. It's created a lot of problems, particularly I think for our local authorities when trying to do planning for next year. Some of the delayed decision making that's happened has been really, really problematic. And I'm grateful actually for the level of support and candour, transparency, but also challenge that we've had from Mr. Biddle, the desk, and the chief exec as well. So I absolutely recognise that's difficult. I think we're in a position to move forward now, and I'm looking forward to working collaboratively with our partners in Portsmouth from now and into the future. Over.
Okay, thank you. Councillor Judith Smythe.
Quick one, and follows on nicely from your great question, Mark. We are particularly worried in Portsmouth. We're very well run financially in comparison with some authorities. We understand that Hampshire's facing quite considerable financial challenges at the moment, and so is Southampton. You've got a really difficult job if you want to sort of equalise outcomes and equalise some of the non-statutory changes to the system that you need in order to save money and arguably improve patient care. How are you going to make those decisions when arguably we are still providing non-statutory services that help with things like bed blocking and other things, and both the surrounding authorities are going to be unable to do that and are making cuts in those areas as we speak?
Yeah, thank you, Councillor, for another really great and challenging question to try and answer this afternoon. I think that we have to move into a prospective rather than reactive position and work with partners to look at how we can deliver the best that we possibly can for residents. I think that the variables that you've cited with the other local authorities in different financial position or heading towards financial challenge a lot sooner perhaps than Portsmouth is definitely something that creates a huge amount of risk, particularly around some of the services that are part of the consultation, for example, that's been issued by our partners in Hampshire County Council. I think that we have to use the integrated care partnership in a different way to help drive some of the strategy around how we focus attention. I think we need to learn profoundly from our experiences over the last 6 months in particular, to help us improve the way that we work together. And I think we've got to do quite a lot of work aligning our budgets to shared strategic objectives. So I don't have the kind of detailed answer. Here's the plan of how we're going to do it, Councillor. But I think, again, we've got to take advantage of the fact that we're now in a better place in terms of looking forwards, to look forward together, and try and make sure that we do proper risk and quality impact assessments on anything that comes to us as a decision to take about whether we do or don't do a particular thing. Over.
Thank you. Councillor Smythe, do you have any follow-ups on that? Okay. So Dan,
Chair, there are discussions we should have later about it, but I don't have particular follow-ups today. But I think it was good to. I'm glad to have got the elephant in the room out there, because it's a very serious situation, and I think it's going to cause a lot of difficulties. Thank you,
Dan. Thanks for coming today. I did want you to have a heads up that I also wanted to ask some questions about the stroke recovery service. So I didn't want to ambush you at this. So in Portsmouth, the Stroke Association has historically done a lot more than other areas of the county, and with more complex needs and services. So I know that Portsmouth City Council has been backfilling funding where other areas, which other areas don't fund. And I know that Port City Council has written to the ICB to see if they will fund in future. Do you have any update for members here on that?
Yeah, thank you, Chair. And I'll give you the top line update, and if there's more detail that is required, we've got Bernie Allen from the HCP team online to field any further questions. But in essence, we are working towards that, in essence, with the Wessex Alliance. We've got a piece of work ongoing looking at the pathway development for stroke rehab, and I fully expect that we'll be commissioning that.
So would that be within the financial by the end of this financial year, or by December 2024?
I think the deadline for completion, Chair, is at the end of Q3 in this financial year. I have to say, I think we probably need to speed it up a little bit, if I'm totally honest with you, because that seems like a really long time to do something that maybe we could do a bit more quickly. But leave that one with me, and I'll do my best to expedite getting to the end of the story on that. Over.
Would you be able to either write to the leader and chief executive of Portsmouth City Council to give an indication of or come back to the next meeting and let us know?
I'd be delighted to do either, Chair, or both, if that's better from a governance perspective.
I mean, obviously, from Portsmouth City Council's perspective, quicker the better. So if it's an email to the chief executive and the leader, that's obviously quicker than the next HOS meeting, so that would be useful. So I'm opening up this bit to other members. So Councillor Graham Heaney.
Yeah, thank you. Well, thank you, Dan, for that update. I mean, I've been involved with this issue for quite a while, and the council agreed at its budget meeting to continue funding to the end of the financial year, which is helpful, because I was concerned that we reach on a cliff edge with December as a possible date of money running out and no decisions. So I'm very pleased to hear that there is a process for looking at stroke recovery services, and also that a possible tendering exercise, because I'm assuming you're talking about a tendering exercise for services, would be starting reasonably swiftly. I mean, I'm presuming you're working on the basis of the national guidance that's been sent out about stroke recovery services. Is that right? You're using that as your basis for the work you're doing on this?
Thank you, Councillor. I can see Bernie smiling because I'm going to turn to her, but yes, is the short answer. Bernie, I don't know if you want to add or expand, please.
I'm more than happy to, if that's okay, Chair.
Yes.
Okay. Yeah. So absolutely, we are working with the West Integrated Stroke Delivery Service to develop the detailed model. It is a model that replicates the national guidance. If I get all my S's right, just for the minutes, it's the Integrated Community Stroke Service Model, helpfully referred to as ICSSM, and that is all of the good practice elements and guidance that came out from the Department of Health. It was published in February 2022. Apologies, Chair, I did draft a paper to support this part of the conversation, but because the question came after the distribution of the full pack, I can send it straight after to you to have that detail in there if that is helpful, and that will contain with that level of detail and information.
Yes, please. That would be very helpful. Thank you. And I'll circulate it to members here. Councillor Heaney, did you have a follow-up at all? You're on mute. You're on mute, Councillor Heaney.
Just does it without me doing anything to it. I don't know whether you're in a position to clarify this, but are we talking about an in-house service, or are we talking about a tendered service, or a mixture of both potentially for this? I mean, I understand it's a more detailed question. You might not be able to answer it, but that's the sort of question I'm interested in knowing something about.
Sorry.
Yeah, sorry, Bernie. I was just going to say that's the work that's being done at the moment, Councillor. So as I committed to the chair, we'll do everything that we can to speed it all up so that we can get to a clearer position. And I'm sure through Bernie, we'd be happy to share any updates in future.
Thank you very much indeed.
Are there any more members' questions on this particular element? So thank you ever so much, Dan. I know that was probably a bit tough in parts, but there is frustration in Portsmouth about these outcomes. So thank you for coming today. The report's noted. You're more than welcome to stay for the rest of the meeting, but I understand you're busy and you might need to go. So thank you very much.
Well, Chair, thank you so much for the opportunity to come and talk to the panel this afternoon. I'd be delighted to come back in the future if you'll have me, but with your permission, I will step off this call.
Thank you. So next item is agenda item 6. So health and care Portsmouth update. So we've got Bernie Allen. Bernie, could you give us a brief summary of your report, please? And then members will ask questions. Thank you.
Thank you, Chair. So I will take the paper as read, and I will also try not to steal the thunder from Mark Rowland and colleagues from Portsmouth Trust, University Hospitals Trust, that I know are further down the agenda, and that the urgent and emergency care work and the fire break work forms quite a significant part of their update, and it's better to hear it from them directly. Although I did just want to sort of share the context in which that work is happening and across the ICB. So, our UEC departments, our urgent and emergency care pathways experience significant pressures nationally at the moment. And our attendances at emergency departments and the subsequent admissions to hospital have been as high as they've ever been. Tentative figures, but mid-March we have some signs of recovery of improved performance against some of those key measures. And, areas that we have struggled with, the discharge volumes are doing well to keep pace, but that means we're not seeing necessarily the improvements we would like to see around the numbers of patients who are remaining in hospital longer than they're medically fit. We'll continue to work on that, and particularly in Portsmouth and South East Hampshire, we have been participating in those fire break weeks that I'm sure Mark will refer to and does in his report. In terms of the other elements that are included in the report, I'm really pleased to note the positive outputs of our work with the Mental Health Hub and the access to the services that we're providing through that, and some of the initiatives that are showing success in terms of access to physical health checks for people with severe mental illness, particularly some of that work with our specialist pharmacists that I would like to draw attention to. And that's a pilot that has worked significantly to increase access for that group of patients that we will continue to roll out. And similarly, some of the physical health improvements that we've been supporting and funding through the Portsmouth Provider Partnership in terms of access to physical health activities for those residents with mental health diagnoses. Lastly, in section 3 and 4 of the report, I think a real champion or area of note is the continuing work for populational engagement with our communities in Paulsgrove and Portsea, which is supplemented by a further event and pieces of work that we are supporting in the Somerstown area with the Rock Conversations this afternoon and this evening at King's Church, which I'm really excited to be going to alongside other members of Health and Care Portsmouth. I won't say anything more, but of course happy to take questions through you, Chair.
Thank you, Bernie. I represent part of Somerstown, that part of Somerstown, so it's really good to see that happening there. So members have read the report. Have members got any questions at all to Bernie? Councillor Ashwell.
Thank you, Chair. Thanks for your report, Bernie. So you mentioned at the very beginning that there's extra pressures on the hospital now. Is that because people just coming direct to the hospital and not going to see their GP because can't get an appointment?
It's a mixture of things. I think we are seeing an increasing level of unwellness across all populations. And I was going to update on access to GPs as part of my next paper. So I don't want to step out of kilter. Okay. But yeah, we do have a level of unwellness that is increasing. We see an increasing acuity of patients at all our hospitals. That isn't unique to Portsmouth, although we sometimes refer to it as, being aggravated in the city. It wouldn't be fair to say that it's just about seeing a GP when we quote those numbers. We have full access at our practices to professionals who can give the help, and in that way we share. We do manage to see an equal number of people in our populations relative to other places. They just don't see a GP; they see someone else.
Okay, all right. I might ask the question again later. Then, thank you.
Did you have a follow up at all, Councillor Atchwell? Was that okay? Okay, I think that's okay. Any other member question on this agenda item? Okay, so thank you very much for that. We note the report, and we'll go on to agenda item 7, which is access to primary care update. And Bernie.
Thank you, Chair. So again, the paper follows its standard form. Unfortunately, at the time of the sequencing of papers, we hadn't got the January numbers ready. But I do have them hot off the press that I'd like to give verbally, if that's okay. So December, we would have recognised a downturn in performance, fewer numbers. That's linked to the number of bank holidays in the month and how they fell. So in January, we increased to 105,471 GP appointments. That was up from the 80,000 number in December. So you can see how the bank holiday really does impact that period, and or also patient choice not to see their doctor in that point in time as well. We can't ignore that fact. Rates per population then also increase correspondingly because we've seen more members, we've seen more appointments. And then the bit about accessing the right care. So if we think about that 105,000 appointments, 44% were seen on the same day. and around 86% were seen within 14 days. Now, that's a slightly different percentage to that seen in December, when we would have, of course, prioritised the urgent appointments with limited clinic time. And we continue to, within Portsmouth, achieve or compare favourably across Hampshire and Isle of Wight, where 80, let me just get my numbers right, yes, 83% of appointments are seen within 14 days. Just moving on then to the rest of the paper, which includes the dentistry access. We refer to the bus service I should call it a bus Dentaid and mobile facility that covers the whole of Hampshire and Isle of Wight. We continue anecdotally to hear very strong positive take-up and utilisation of the service. We are waiting for the first statistical reporting of use. But in terms of local coverage, the Dentaid bus was in Portsmouth in the Summer Towns Hub yesterday, is currently in Cosham Community Centre or adjacent to Cosham Community Centre today. And we continue to see a cycle of visits that covers Havant, Paulsgrove, Gosport, on a rolling cycle. We do not advertise these publicly in terms of access. There's a managed way of contacting the patients who've asked for the help. And this is so that Dentaid, the service provider, can continue to target the urgent members of the population and prevents overwhelm at those services. And because what we don't want is those pictures of people queuing around blocks for treatment. So with our dental providers, we do have a controlled way of ensuring that the people who need the care can register and attend. Chair, I think you're on mute.
Thank you. It's frustrating. I turn it off and it turns itself back on and does it the other way around. So thank you, Bernie. Opening up to member questions. Councillor Judith Smythe.
This is just a quick one, really. The table at the top of page 88 was further confused for me by you mentioning a figure of 83%. I take it that there's a typo there, because 7 to 10 practices delivering over 95% of appropriate appointments within the 2-week timescale doesn't align with what's in that table. In the table, 1, 2, 3, 4, 5, 6, 7 practices deliver over 90%, but not 95%. And then you mentioned a figure of 83% just now. Could you clarify that, please?
Okay, so the data that we're talking about here is the December data, and I was providing a verbal update on the January data. So I've got the verbal.
So there are two questions I've got. One is this table correct? I couldn't make head nor tail of it. But the figure now would be 83% of practices, of the 10 practices, are delivering with service within 14 days. Is that right?
So are you looking at
over 95%?
Sorry, I'm struggling with
paragraph
which
one.
Point.
Paragraph 119.
119.9.
On page 88.
Maybe I'm interpreting it wrong.
I will double check the narrative and make sure that is correct. But yes, this is the December data. But I will double check.
I've got that, but it still doesn't make sense.
Okay, I will follow that up.
Or else I'm being very thick.
Yeah, I'll follow that up. And I will return a detailed answer to the chair.
If you could, please, because at the moment either I'm being very thick or it doesn't make sense.
Yeah, I will do.
Could I ask a question about that?
And I think whilst I'm talking about this, just very briefly, again, last time round, I said we should be publicising much more the relatively good progress that people are. I mean, still, if you go into the high street and talk to people, they're still in the old mode of saying we can't get an appointment for 6 weeks, can never see a GP. And in fact, the figures you've presented us in the last 2 or 3 months do again say that, which is it's very important that we have the accurate figures. So when we meet somebody complaining about it in the high street, we need to be able to know exactly what we're talking about. And I think these figures, even if you just believe the table and derive your own percentage, they are much better. And that indeed would be echoed by my own family experience through my husband, who needs the GP sometimes. And I don't think we're publicising that enough. We need a few good news stories about that in the Portsmouth Evening News, even though it's not widely read, because the man in the street, the woman in the street is still feeling that they can never get an appointment.
Thank you. Bernie.
If I may, Chair, so I completely agree. It is sometimes what we hear locally is the loudest voice, is the unhappy voice. I do know we publish the stats around GP access on a number of forums. It goes out on the Health and Care Portsmouth Facebook type page. I know not always an accurate read of take up, but that is one of our most read and most liked pages in terms of updates in terms of when we share it. So yes, we do what we can to publicise it, and I will double check and make sure the narrative and the numbers stack up so we have some easy facts and figures to be able to quote with confidence.
I don't think that elderly people look at the website, so and that's often the ones that you encounter in the high street during a weekday.
Okay, thank you. That's noted.
Thank you. Councillor Graham Heaney, please.
Thank you, Mark. Do we know why 3 other practices are below the 85% threshold? There's Cranes Water, Kirklands and Unicity. I mean, in particular, the first 2.
Not immediately to hand, but I will find out why and ensure we provide that update.
I've got a question actually associated with that sort of thing as well. So on 115 and 119, I'd made notes that actually there's quite a big difference between, the bottom 3 on 115 and the rest. And also Cranes Water Group Practice, hands up, I go there, and Kirkland Surgery on 119. They're quite a step out of the other averages. So is it part of your remit to do something to question those surgeries, and are there plans for them to make things better?
Let me come back on the detail if that's okay, rather than say something untoward or misleading, which I would hate to do. We do regularly meet with all of our practices. We do quality meetings with them. We talk about different issues, including access rates and complaints and how we are responding to our population's needs. We do have our primary care access plan. I wouldn't like to speak about specific practices without having had the opportunity to go and do that level of detail. So I will follow up on that and make sure we bring a response to that.
That would be very helpful. I've had to wait a month for an appointment, one of those ones. So I might speak to Judith in the street and let her know that. But that would be really useful. So would you be able to do that for the next HOSP meeting?
Yes, you're absolutely welcome, Chair. I will do.
Thank you. Are there any more member questions on this item? No, that's it. Thank you ever so much, Bernie. Two agenda items in a row there, so that your report's noted. You're welcome to stay, but equally we know you're busy. So if you want to go.
No, thank you, Chair. I will stay.
Thank you. So next we've got agenda item 8, which is Solent NHS Trust update, and I think we've got Andrew Strevens as the person that's here.
Yes, thank you, Chair. So
Hi.
Andrew Strevens, Chief Exec of Solent NHS Trust. I will take the paper as read, as it is only, I think, 2 pages within the report. I think the key thing, which is a contemporary update, and there are communications which are going out, is that the creation of the single mental health, learning disability and community trust for Hampshire and the Isle of Wight has been delayed by a short period of time. Our regulator, NHS England, wants us to spend just a little bit more time in terms of preparations to ensure a smooth transition. And within the communication that has gone out today, we're looking at doing things in a staged process. So the Hampshire CAM service has been transferred from Sussex Partnership already, which was on the 1st of February. And we're looking at the transfer of the mental health, community and LD services from the Isle of Wight Trust, hopefully aiming for the 1st of May, and then for the final piece of the jigsaw, the Solent services as of the 1st of July. But we recognise there's a significant amount of work to do. The interim arrangements between now and those dates will come out in due course as each board works through the details of that. I think it's safe to say that we were all committed to the kind of aims of the creating a new organisation, and we are disappointed with the delay, but we will deal with that in an appropriate way. So I just wanted to give that really kind of up-to-date update in terms of the paper, but happy to take any questions you may have.
Thank you, Andrew. So over to members. Are there any questions at all on this item? I had one. I guess the answer will be yes, but I don't know whether you know anything about it and how detailed you might know about it. But in terms of parking at St Mary's Community Health Campus, presumably the trust do some sort of green travel promotion for staff.
Yes, we do all sorts of things. I mean, we do a variety of things like the bike purchase schemes, encouraging people to work. We also actually unusually we have a number of hire cars as well, which is on the Rodney Road site, where a member of staff can use that to do their journeys throughout the day. Again, trying to reduce the level of parking at the St Mary's site. So yeah, absolutely, we do a lot of that.
Good, okay, thank you, Councillor Graham Heaney.
Thank you. I've got two questions really. One is a really simple one, but I'll start with what might be the slightly more complicated one. At the bottom of your report, before you get to parking, suppose you said there will be minimal change to services when the new trust is formed. I don't know if you heard, I asked some questions earlier in the meeting with the ICB about the amount of savings they're going to require, and I understand you're not going to be immune from that. So how can you guarantee that there will be minimal change to services on the basis of no possible significant savings needed to be found?
Yeah, I mean, that sentence, I'll answer it in two sections if that's okay, Councillor. So in essence, that sentence there is referring effectively that the organisations currently within Solent and Southern Health would remain pretty much the same. I'm not expecting any key changes between, say, in the case now between the 30th of June and the 1st of July. So there won't be an overnight change, and any changes that we do would be consulted upon. And I came before Healthwatch, I had a meeting with them last week, again, making that commitment. But if we're making changes to pathways, then absolutely, then we would be bringing that for consultation. In relation to the second element of your question, in terms of the significant savings, I missed most of the section with the ICB, so apologies. But yes, but I recognise actually we are going to have to change some of the way that we deliver services, and anything that we do does go through what's called a quality impact assessment. So we understand, does that make sense or not make sense from a clinical viewpoint? And where there are significant changes, then absolutely we will bring those forward into consultation, both in terms of like for yourselves and for Healthwatch. The things we're looking at the moment don't encompass those things, but in reality, over time, particularly the level of savings that are required from a system, and I don't know whether Dan Gibbs quoted numbers, but there are significant savings that we need to make. Absolutely, we need to bring the public with us in terms of deciding where we prioritise our spend.
Okay. The second question was in relation to the car park. You said that you recently introduced new user-friendly parking machines at St Mary's. Does that mean machines that take multiple forms of payment, or is it something even more spectacular?
The answer is I can't answer that. I think the reality was, I think our previous provider, I think there were a number of issues in terms of how it operated. I think this is more user friendly. I haven't seen any statistics, to be honest, to back it up. But I can see Councillor Jeffrey nodding. I think he's saying it's more user friendly. Okay, right, there we go.
Well, he's used them, and he can provide a user perspective on it straight away. I mean, I just my thing about when we have parking meters and machines, I think we need a variety of ways in which people can pay, rather than concentrating on more somewhat, let's say, more high-tech forms of payment, because it is a pain to find that you've got to go and have a different way of paying. But anyway, I'll leave that there.
I think the from my memory, a couple of weeks ago, I think there are more ways of doing it now. So from my user experience was, I noticeably thought it was better, but that's just my personal.
Okay, we'll take the chairs as a here on that one, then.
Okay, so next I've got Councillor Judith Smythe, please.
Just to pick up a sort of theme that we had before when talking about the need for recognition of the different initiatives that are done in an integrated way with local authorities. Portsmouth has made a lot of progress on housing and also preventing homelessness, housing homeless people, preventing homelessness. Many of the people who pitch up in our homeless pathway have mental health problems, sometimes dual diagnosis with substance abuse. And we've enjoyed good cooperation with Solent in the past to try and get additional money to put additional members of staff where those people are. People who are homeless, or particularly those with a dual diagnosis or a single diagnosis of mental health problems on the top, do not make their way up to St Mary's even. They find it difficult to travel. They don't like going to appointments. They don't find it easy. We're in a waiting room with others. And I think that these services that we've done jointly with Solent in Portsmouth, based quite a lot on additional grants that we've got as a city from the central government to help, have been staggeringly successful. And I would hate to see that the move to a larger and essentially less manageable mental health trust across the whole of Hampshire, where problems are all different everywhere, will result in those additional resources being lost. And if they are going to be lost, you need to give quite a lot of notice of that, because we could actually harm the outcomes for individuals if that's summarily. Can you give me any reassurance on that, please?
Yes, and I'll try and do it in a variety of different ways. And I know Andy Biddle's on the call, but I'm really proud about how Portsmouth City Council and Solent have worked together, hand in hand, joint posts, both in terms of our children's services, our adult services, physical services, but also our mental health services as well, and how we have joint teams of social care workers with our kind of clinicians and nurses in the community. And that has worked tremendously well. And actually, you would recognise that we have very limited inpatient beds in the Portsmouth system, because actually most patients are treated out in the community. And we have a huge amount in terms of that signposting for homelessness and finding shelter and the rest of it, which I'm immensely proud. There is no intention to reduce the funding within the Portsmouth system for the new organisation. We want to level up rather than level down. What might happen is when there is new investments coming down from the national government, they may get more siphoned to other areas of Hampshire where there is significantly more unmet need, but there is no intention at all to reduce the investment within the Portsmouth system.
Thank you very much. I mean, I hope we've got that recorded. That's great, and I agree with you. That's the right thing to do. We did air the problem of at the present moment, Portsmouth is financially stable, well run. Hampshire County Council and Southampton appear, if one believes what one reads in the press and so forth, to be struggling and much more challenged. I think you need to bear in mind the need to be fair to the citizens of Portsmouth and really keep up with those funding things, because we have invested to save over years, and I'm really impressed with what we've done, and we don't want to see your resources making up for cuts in the other authorities, I think.
Thank you. Councillor Smythe. Yeah, we are proud of our homelessness work. So the worst possible thing would be if we get dragged backwards. Yeah, that's a very good point. Do we have any other member questions at all? No. Okay, so thank you very much, Andrew. We've noted your report. You're welcome to stay, but equally, if you need to go, we understand. I need to go, but thank you very much for the time. Thank you. Bye-bye. Thank you. Okay, so next we've got agenda item 9, Southern Health Update. So as members, we've read the reports. Nikki, could you please give us a brief summary of your report, and then members will ask questions.
Yes, thank you, Chair. So I'm Nikki Crichton-Young. I'm the Director of Operations in Southern Health. The overview of the report touches on the Project Fusion update that you've just heard from Andrew. So I'll take that as that is representative of obviously the update position from Southern with regards to Project Fusion as well. The other areas, the leadership arrangements that we've been progressing within Southern Health around our acute and crisis mental health pathway. I've made reference to you just to give you some assurance from the industrial action, whilst there was some implications of that in terms of particularly clinics and services that weren't able to go ahead. We had a really positive response from our medics and colleagues across the organisation, and having been a number of industrial action strikes, we were well prepared and therefore managed and mitigated those risks. And in addition to that, the report just covers some key highlight areas in terms of improvement plans that are supporting the wider system as community mental, physical health provider service. So I'm happy to accept that you've read the detail, and then if there's any questions that you would like to ask with that regard.
Thank you, Nikki. Okay, over to any member questions. If any members got any questions, please let me know. No? Okay, well, thank you very much for your time. We've all read the report, so thank you very much.
Thank you, Chair, thank you.
Okay, so the report is noted. You're welcome to stay if you want to, but equally, if you need to go, please do. Thank you very much.
Thank you very much, Chair.
So next we've got agenda item 10, the PHU update. I think we've got Mark Rowland and Lee McFell here. So Mark and Lee, could you give us a brief summary of your report? We've read the report, and then members will ask if they've got any questions. You're on mute.
Unmute. Just me, I'm afraid, Chair. Lee's not been able to join us. I'll take it that the report's been read, and we'll just bring out the key points. A very challenging winter. Our historical highest attendances in that time, I think 450 ED attendances, of which over 300 were actually walk-ins on the day, which we looked at in more detail in terms of trying to understand where those people were coming from, why. A very pressurised organisation, pressurised ED, pressure on the ambulance service, and therefore delays to responsiveness to the ambulance service to members of the population, bringing additional risk. We have had Lee McPhail join us as an interim delivery director, and he has instigated a series of fire break weeks leading up to the Easter bank holiday. We've had 2 fire break weeks now. The 12th to the 18th of February, 4th to the 10th of March, and the last one's 21st to 28th of March, so leading right up to the Easter weekend. One of the main ambitions of them was really to bring community partners together, and we've come together on 2 occasions now. There's been an opportunity for other providers to actually be able to come around the hospital with us to see how ED is, how the bedded same-day emergency care areas are, to look at some of the examples of our surge areas and corridor care, the fact that we have bedded patients in theatre recovery areas, just to get a feel for the impact of very high occupancy on the organisation. Because I think if you don't see it for yourself, it's actually quite hard to picture the impact that it's having on patients and staff. We did a lot of really focus work together, try and address patients who are in the hospital who no longer need to be there. Some of the really concentrated work in that first week related to patients who'd had very prolonged admissions related to mental health issues, and we were struggling as a system to actually find appropriate placement for them, and we managed to help a couple of very long-staying patients to appropriate and safe transfers. In the second week, we actually did have part of our emphasis was homelessness. We had 11 homeless patients in the hospital at a time who we were struggling to find a place for them to go. And so we had really helpful presentations from our ED team, who run a multi-service collaborative service to support homeless patients coming to ED. A lot of really helpful, it all came together very well in terms of seeing the amount of work that was being done in that space. We did a lot of additional work. We looked at a different approach in terms of therapy, with therapists potentially seeing people in anticipation of their becoming medically fit to leave rather than waiting for that time, with some evidence to show that earlier intervention would get people back to their home or place of residence a day earlier than the current process. We also had a trial of, I think it's called Drop and Go, where ED literally drop patients, where SCAS drop patients into our waiting area without waiting for a formal handover, with the handover occurring through the electronic delivery of information that they have. We've had quite a lot of eyes on the front door, particularly those walk-ins, both over the 2 episodes, trying to understand more about why people are there. And I think at the present time, we think about 40 to 50% of the people that are there are people that could easily have been managed within primary care. So we're just coming to the end of a pilot now, where we have had 2 GPs in the ED running through from about 2 p.m. till 10 p.m. in the evening. It's not been consistently resourced, but where it has been there, they have made a big difference and managed to turn a lot of patients round in a way where the patients actually had the reward of being seen by a healthcare professional and had some advice, which is what one would hope for. So I'm sure that you'll probably have more questions about that. I think the outstanding thing that we really wanted to flag further in the report, which we're very proud of, is the fact that the CQC maternity report rated the service as good, and there's content there you'll see, which we're very proud of. No small testament to Lynn Woolley, the Director of Midwifery, who has unfortunately retired a couple of weeks ago, but a huge team effort, and I think they have come such a long way in the last 5 years. And where we see so much distress at times related to maternity services nationally, I think it's really encouraging and positive for us to get such a positive report from our regulators. So I'll pause there and open to any questions.
Can I just ask a quick question mark on that? So did it move from what to good? Do you know?
I'm not entirely sure what the previous rating was. I think it might have stayed at good, actually. Okay. But again, I think the scrutiny is so close on maternity services at the present time. I think that it is a really great achievement to achieve or maintain a status of good in the current climate.
Yeah, okay. One of the things that I wondered was, I mean, the fire break thing sounds like it's working or has worked well so far, but why, as a layman, why doesn't that happen normally? Why isn't it normalised?
And I think that's the ambition, and I think the difficulty, and I think we've explored it a little bit with some of the other people who have presented reports this afternoon, is that when you have a whole health and social care system under immense stress, both operational stress and financial stress. It is incredibly difficult for people to come together sometimes and just put everything aside, and this is what we're going to do, and we're going to do this together. And that was one of the ambitions of the firebreak, was to try and give people a space to be able to do that, because I think that when you're under so much stress, as much as people try, however much goodwill there is, it is quite hard sometimes to come together in quite that way. And I think the feeling was from the first firebreak week that people came in, I think almost as if coming in from being in a war zone into a room where you're still in the mindset where you're a fighter, it's fight or flight, the adrenaline's running, what can we do? And of course, when you're in that headspace, you are relatively defensive. And actually, as the week went on, we moved into a much more collaborative dialogue. I think on the whole, and I'd say it for Portsmouth South East Hants, and I've been here in the system for over 30 years now. I think, no, it's not 30 years, it's 20 years this year. I've been in the system for a long time, that we do have pretty strong working relationships in Portsmouth South East Hants. I think probably, better than perhaps some other areas in the country. But I think that even the best relationships get tested during periods of persistent extreme pressure. So it's been really helpful and rewarding. And I think it's an investment in trying to remember the ways that we need to work together to get the best outcomes.
Thank you. That's helpful. So we've got quite a few member questions here. So what I'll do is I'll go to members in order. If you've got questions on the same topic, you can have follow-ups, and then if there are separate issues, we'll come back to you at another time. So Councillor Judith Smythe.
These should be very quick. First of all, I think we should note with pride the reassurance that the CQC maternity. I don't think we're just noting this. It's a really good achievement in this day and age. I think I'd like to pass on personal and up from all of us. So congratulations to the team in retaining that good. It is significant in this time. Now, the second thing is I'm intrigued as to what the bottom of page 101 should have said. It said, building better emergency care progress. We were recently joined, and I was intrigued to know what that was. Just very quickly, if you could tell us to ignore it or to see what was missing, I'd be very grateful.
Yes, I think that's we've had a number of external visits recently. I read that and was guessing at what was supposed to be on there, but we had the National Clinical Director for Emergency Care join us and gave support and advice in terms of our progress with a view towards building better emergency care, which is basically the project working towards the opening of the new emergency department. And we also had a GIRFT visit as well. So we currently also have ESIST on site. So we have a lot of support coming in, and actually they're all adding great value in terms of the narrative and guidance. So I suspect that's what they intended to describe.
Thank you.
Perhaps we might have a further report on the outcomes from those visits and the overall programme. I think it's an important one, but thank you.
With pleasure.
Thank you. So next I've got Councillor Anne Briggs, please.
Thank you, Chairman. I'll just start by saying I hate to be really critical because I know you try and do your best. But as a Hampshire County Councillor, at our HASC, we get reports on all the hospitals, and QA, which is my hospital, so I care very much, comes very low down in ambulance handover times, waiting times in ED, and everybody is so concerned. And every time we get a report, it doesn't seem to get better. You might have improved somewhere, but somewhere else you haven't. And every time there's winter, you say, well, we've learned from last winter and we're going to improve this winter, but it doesn't. Now, is it because of the increase in population? And in Hampshire and to the north, we're having 2 new hospitals. Do we need something more in the south? And my other question is, everything's about discharge, which doesn't always work. Now, originally, going back years ago, from the moment a person was admitted into the hospital, there should be a pathway for their discharge. That doesn't seem to be happening. And only today, because I just nearly missed this meeting because I was out seeing residents, someone's had a daughter in hospital, taken in from not this Tuesday, but the other Tuesday, and they're still laying there waiting for their scan. I mean, that is bed blocking. So I don't know if you can answer and reassure me, but everybody at the HASC, which people are all from around Hampshire using different hospitals, were utterly appalled at the time it takes people to get through ED in Portsmouth.
Thanks, Councillor. And I can't do anything other than reflect the fact that that is the experience that people are having in Portsmouth hospitals in the emergency department recently. I can say, as has been the case for some time, that we're doing a lot of work to try and improve that. What we have seen is increased attendances over time. Over the last 4 years, the attendances have increased steadily. We're seeing increasing complexity, frailty, multi-comorbidity in the people attending. We're seeing higher levels of acuity. We do see an overfull hospital, and high occupancy in the hospital obviously is a major contributor, if not the core diagnostic, in terms of having outflow block from emergency departments, delays in emergency departments, ambulance handover delays, and all the difficulties that causes. And yes, there is a focus on discharge, which I worry is a dirty word, but actually I think that it is a really positive thing to actually succeed in completing your admission and being able to get out of the hospital. And actually, from an occupancy point of view, so our occupancy levels, I think the chart you're looking at there showed 105% bed occupancy in January. What does that mean? That means on top of 1,000 beds, you've got about another 130, 140 escalation spaces. I mean, we're talking about trolleys on corridors, on wards, etc., that are they were never planned to have patients in them. And when you have those very high levels of occupancy, your efficiency reduces. It is incredibly difficult to reduce flow, to provide flow. And actually, one of the greatest tools that there are in terms of trying to bring occupancy down is to reduce length of stay, try and get people home a little earlier. Even half a day makes a difference. So earlier on the same day makes a difference. So it's a difficult situation. We now have ESIST in for this forthcoming week, coming up to Easter for the current fire break. We're doing everything that we can to try and improve the situation. Indeed, I just got an update on our figures because we had seen, so we were cycling around 210 medically optimised for discharge or non-criteria to reside patients before the first fire break. Second fire break, cycling about 180 patients. And now today, I think we were on about 150. So the fire breaks are having an impact, and our month to date position in terms of ambulance handover within 15 minutes, because you can see that trend down into the 30% range, is 57%, with the 4-hour performance up to 65%. So we've seen some glimmers of recovery. Those that have followed the story closely over the years will know we get good spells, it becomes more difficult again. So it's how do you break into a cycle of delivering that more consistently? I think one of the challenges is that the answer is not in having more and more people coming to the hospital and having a bigger and bigger hospital, basically. The answer with an evidence base associated with it is to try and support more people to have care in their homes or closer to their homes over time. And actually that perhaps applies more for some of our frail elderly than even for other cohorts, because the frail elderly decondition, as we all know, significantly in hospital and will often have increased health and social care requirements after a spell in hospital that they wouldn't have had if that admission been avoided. That's certainly a focus of a lot of the work that we're doing in Portsmouth South East Hants. It's something that Nikki Crichton-Young, who was just on, and I have been doing work together on. We need to go further, and to go further will require integrated collaborative working, basically. So I understand that tension that we had in terms of where does the ICB sit. I think they create the conditions in which it becomes easier for us to collaborate and integrate locally. And I think some of the tensions that I described earlier have perhaps been a barrier to that integration, and we're working on that. Sorry for a rambling response, and I hope I covered some of the things that you were asking about.
Thank you. It is just very concerning when people say, I'm not going to bother to go because I'm going to wait for hours. Do you think the UTCs are advertised well enough? I mean, we've got a good one at Petersfield, but it's not 24/7 and they don't always have a radiographer. So if you break your leg after 4 o'clock, there's no point going there because you can't have an X-ray.
I think the three UTCs, I think the Petersfield one, and I'm not an absolute expert on the data related to each UTC, but I think the Petersfield one is probably the one that has the smaller offering. But I think Gosport have seen, I think it's something like a 200% increase in attendances over the last couple of years. They're working incredibly hard and I think delivering a good service. They have 98% performance in terms of the 4-hour wait in Gosport. And I think the St Mary's unit has been very effective as well. I think they're providing a service for Portsmouth City patients that I think without that, the situation in terms of where we are with ED would be considerably worse than it is. I can't comment specifically about where Petersfield are and that, but no, they provide a valuable contribution. I certainly know from all the communication that we provide as a hospital through various different media and the various different recordings I've done for radio and television, and we're always signposting people to access those resources.
Thank you very much. Thank you, Chair, for letting me ask those questions.
Thank you. Actually, it's really helpful because I know that we've talked about this as members in the past, that we don't get to see any context of how, for example, the trust compares, or the hospital compares to other areas. So, and obviously sometimes there's no reason why organisations would actually tell us either. So I don't know whether we need to do some behind the scenes work to be able to get that information. But I'll perhaps contact you offline about that.
Okay. I mean, I would imagine a lot of that information is relatively easily available in the public domain. Portsmouth Hospitals, obviously, we want to be transparent in terms of showing you where we are. We are in a difficult position. We have a lot of work to do. There's no getting away from that.
So would you be able to give us, whenever you have a report like this, would you be able to give us comparison figures with other places in Hampshire as a matter of course?
I will need to check, obviously, but given that you are scrutinising care within Hampshire, it would seem appropriate that you would have that information available to you.
Thank you, Mark. Thanks. I've got Councillor Graham Heaney, please.
Yeah, thank you, Mark. I just want to go back to the question of the fire breaks, and I think you may have answered the question that I'm going to ask if I understood it correctly. What I was going to ask was the fire break in February, the one in March. Did you see a continual improvement, or are these not a dropping away after your fire break week? Did it have a longer term effect than just that week?
Yeah, because we see dips in medically optimised just as a routine course of cycling in terms of our discharge plans over a weekend. So we'd sometimes come into a medically optimised position on a Monday of about 170, but it would pick up during the course of the day into the low 200s just as teams come on and all the patients are reviewed and patients have progressed over the weekend. So I've been watching to see, do we bounce back? And we've been as low as 130 people in the hospital with non-criteria to reside following fibre week 1, which is the lowest I've seen it in a long time. It's cycled to a fairly steady position around 180, which again, if you think we were cycling in the 210 to 230 range, represents a ward less of patients who are in the hospital who don't want to be there and are waiting for something else to happen. This week, we've been around 150 after the second fire break week. I'll just have a look at this morning's report. Our position was 159 at 6 o'clock this morning, and we seem to be holding around that 150, 160 range. So I think it has had a stepwise impact, and that's something that we felt, and we have seen. We had a fantastic week last week. I don't think we had any ambulance handover delays of over 30 minutes last week. We've had a much harder start to this week, so we have seen significant ambulance handover delays for this week, but I'm hoping that that lower number of people in the hospital who no longer want to be here or need to be here will mean that we can recover that more quickly. And certainly where we've had better periods historically, it's not just avoiding delays, but it's actually recovering from spikes rather than getting into a difficult cycle that takes you weeks to recover from. So it'd be very interesting to see how rapidly we recover from the last couple of days, which have been quite difficult.
I suspect because you've only done a couple of them, it'll take a little bit of time to just see the long-term effect. I mean, after 6 months or maybe more of that, we'll know a bit more about how effective it's been. So that's really interesting. So thank you for that.
But just to emphasise, there's so much work that needs to be done and to continue to be done on so many fronts to try and support this being in a better position. And the fire break week work has been great. The collaborative approach has been really inspiring. The support to get more people out of the hospital has been very impactful, but it's not anything that we could take for granted. We have so much more to do. And I think that piece about working together to try and support more people to have care that doesn't require them to be coming to ED or processed through a conventional hospital pathway is fundamental in terms of the future of the hospital and the population that we serve.
That's an important message to take back when we're having our discussions with the ICB as well, I think. Yeah, thank you.
Thank you, Mark. Are there any other member questions? While members have a quick thing, I found it really useful actually that so some of the charts on pages like 107 and 109 went back to 2019. I think we've certainly with other organisations we've asked for longer sort of trends and stuff, and that's really helpful to see. So thank you for that. Are there any other member questions? No. Okay, so we note with pride the CQC maternity report and note the report. Thank you very much, Mark. It's the end of the meeting. Thank you, members. That's all on the agenda today. I officially close the meeting and will ask Lisa to stop the live stream. Thank you.
Thank you.
Thank you, Chair.